Hi everyone, and in this video I'll be discussing another exciting topic, that is antidepressant drugs. We all know that depression is nothing but low mood or sadness. Scientists have thought why this depression occurs. They have put forth some theories. That is, whenever there is decrease in norelin, whenever there is decrease in serotonin, or whenever there is decrease in brain-derived neurotrophic factor, there is a chance of depression. So whatever antidepressant drugs, what we are going to use, they are known to increase the activity of norelin, serotonin, or they are going to increase brain-derived neurotrophic factor, right? So historically, if I want to discuss, there was a drug by the name reserpine. So reserpine was the drug, and that is used to treat hypertension. Now the mechanism of action of reserpine is it's a VMAT inhibitor. It's a VMAT inhibitor. Now when you inhibit that vesicular monoamine transport inhibitor, so that it will decrease norelin, it will decrease serotonin, it will decrease dopamine. So what happened? Since it was decreasing norelin, it was used to manage hypertension. But later what happened? People started committing suicide. There was a risk of suicide when reserpine was given. The reason is it depleted these things. So that's why the drug is banned nowadays. It is not used nowadays. So then we propose a theory, because if we increase these things, we can treat depression. But you know that dopamine causes psychosis, so we don't want to increase dopamine in the person's brain. So what we need to increase is norelin and serotonin. Another important interesting thing happened in history. I'll just explain that. One more interesting thing what happened in history is there is a drug by the name iproniacid. Now this iproniacid was used to treat TB. It was the first drug which was used for TB. It looks similar to some other drug, isoniazid, correct? So before isoniazid, iproniazid was used, and this was an observation. Whoever were given iproniazid, they are very happy. The reason is iproniazid is a MAO inhibitor. It's a MAO inhibitor. Now what is the role of MAO? The role of MAO is it is called as monoamino oxidase. So there are two important MAO, MAO A and MAO B. MAO A, remember, it metabolizes all. What are the all? Noradrenaline, serotonin and dopamine. MAO B metabolizes D, that is dopamine only. So when I inhibit MAO enzyme, what happens? These levels increases, and that is going to treat the depression, and that's the reason when the iproniazid was used, people were very happy. The people treated with TB were very happy. So this led to the theory that if I increase the noradrenaline, if I increase the serotonin, I can treat depression. Then later one more theory came, that is increasing the BDNF. What is BDNF stands for? It is brain derived neurotrophic factor. I'll write the full form now. It is called as brain derived neurotrophic factor, BDNF. So these are to be elevated. So our aim of therapy in depression is to increase these things. So let us start our journey. Before I start my journey, how do I increase these levels in the brain? Now we know that there is synapse. So let me write the synapse for you. This is for the noradrenaline. And one more synapse, let me write. This is for the serotonin. Okay, so these are the things. Now, whenever the norelin is released, the norelin is taken up back. It is taken up back, and we call it as reuptake. So norelin is taken up back. Now again, this is the vesicle from where serotonin is released, and it is also taken up back. So we call it as reuptake. And we have a transporters which can take it up, that is called noradrenaline transporter and serotonin transporter. Now what happens when the noradrenaline enters inside and serotonin enters inside? They are metabolized by the enzyme MAO. The enzyme which metabolizes them is MAO. Now you pause the video for some time and tell me, how do I increase the activity of norelin and serotonin in the synapse? That is the purpose of our treatment. How do I do that? Yes, come on. Yes. Either you inhibit the reuptake, so the drugs inhibit the reuptake, or you can inhibit the MAVO. So you can inhibit the MAVO. So we have two important targets. Number one, the MAVO inhibitors. That is one thing. Second important is the reuptake inhibitors. Reuptake inhibitors. So we'll discuss them one by one. First we'll discuss MAVO inhibitor and then we'll discuss reuptake inhibitors. Right? Let us discuss them. So the first one, what we are going to discuss, they are MAVO inhibitors. MAVO inhibitors, monoamino oxidase inhibitors. In MAVO inhibitors, we have irreversible inhibitors. So the irreversible inhibitors are tranil, cypramine, iproniazid, and then isocarboxazid. So these are irreversible MAO inhibitors. Then we have reversible ones. Reversible ones are moclobemide and one more is chlorgyline. Sir, should I remember these drugs? So please remember, these are not so much important. You need not remember their drug names. So remember, these are drugs called MAO inhibitors, but we are not using them nowadays. We are not using them, only historical importance, MAO inhibitors. Now, there is a reaction called cheese reaction, which we have studied in ENS. Let me repeat that here. What do you mean by cheese reaction? Now, what happens is, let me write the gut here. This is the intestine. This is the intestine. And these are the intestinal cells. Now, before I come to this concept, we know something called tyramine. Now, what is tyramine? Tyramine is an indirect sympathomimetic. That means this is the synapse. This is the synapse. And norlin is released from the presynaptic terminal. Now, what happens when you give tyramine? Tyramine enters inside and releases norlin into the synapse. So it's an indirect sympathetic. So tyramine is a sympathetic, but it acts indirectly because it releases norlin, which acts on the alpha and beta receptor, right? Now, you know this concept. Another concept what you need to understand is the intestinal cells have MAO enzyme. What is the point here is, whenever a person eats cheese contains tyramine. They contain tyramine. So whenever the person eats cheese, he will also take tyramine inside, and tyramine will not be absorbed because it is metabolized by MAO. So no problem. You can eat cheese because we have MAO enzyme working. But if the person is already on MAO inhibitor drugs, particularly the problem is in irreversible MAO inhibitors, not with reversible. If he is already with irreversible MAO inhibitor, what happens when you eat cheese? The tyramine will not be metabolized and it enters into the circulation. Once the tyramine enters into the circulation, it releases norlin, and the norlin released will increase the BP. And this increase in BP is what we mean by cheese reaction. It is called as cheese reaction. Now, how do I manage this BP? By using antihypertensive drug, and that is an alpha blocker called phentolamine. So that is used to manage this cheese reaction. So is it only with the cheese? Tyramine is not only present in cheese, it is also present in beer, wine and all. So why it is not called beer reaction, wine reaction? Because it is same with cheese in the beginning. So we are retaining the name, that's what. So apart from this, MAO inhibitors are not at all used nowadays because of more safer, more efficacious drugs available in the market. So that is only point you need to understand is about the cheese reaction in this point. So the second group of drugs, as I explained to you, they inhibit the reuptake. So the second group of drugs are called as tricyclic antidepressant. So they are called as tricyclic antidepressants. So we call them as TCS, in short, TCS. Now, what is their mechanism of action? The mechanism of action is two important mechanisms of actions. What are those? Number one, they inhibit noradrenaline reuptake. They inhibit noradrenaline reuptake, and they also inhibit serotonin reuptake. That is fine. Now, what is the mechanism exactly here? Now, let me write the synapse here. Now, these receptors, these terminals have autoreceptors. Now, what is the role of autoreceptor? Let me take an example of norlin. So, in an autoreceptor called alpha 2, now what happens when we use these drugs TCAs? Norlin should always be taken up back. Now, this is inhibited. What happens? Norlin increases. And what is the role of alpha 2? Is to decrease norlin release. The role of alpha 2, a autoreceptor, is to decrease norlin release. Now, please understand, norlin is not allowed to be taken up back now because of drugs. So what happens? This norlin keeps on working on alpha 2. So what happens if you repeatedly stimulate a receptor alpha 2 again and again? The receptor will undergo desensitization. They undergo desensitization. So now the receptor will not work. So what happens in the synapse? There is increase in noradrenaline release. And that is what we require to treat depression. I'll repeat again. In any synapse, we have autoreceptor. I will take an example of noradrenaline, that is adrenergic receptor. The role of alpha 2 is to decrease noradrenaline release. Yes. Now, when we use the drug, noradrenaline is not taken up back. This, which is staying inside the synapse, will act on the alpha 2 and desensitizes. When it desensitizes the alpha 2, the noradrenaline release increases, and it will not happen in 1 day, 2 days. That's the reason antidepressants take 2 to 3 weeks to start working. So they don't work immediately. So why this point is important? Because you should not tell the patient, I am giving an antidepressant, tomorrow you will be all right. No. So it will take this desensitization takes 2 to 3 weeks, and a peak effect is seen after 4 to 8 weeks. So peak antidepressant effect will be there for 4 to 8 weeks. That is the time where you see the peak effect. So this is very much important, you tell the patients. Otherwise, patient will think that doctor has given, but still I am not improving. That is one theory. Second theory, I told you, the BDNF, that is called neurotropic hypothesis. So there is one more hypothesis called neurotropic hypothesis. So here, what happens when you increase the noradrenaline and serotonin in the brain? When you increase their level, what do? They are known to increase two important things, that is brain-derived neurotropic factor, and one more is increase the nerve growth factor. So NGF stands for nerve growth factor. So you know that growth factors act on receptor tyrosine kinase. RTK stands for receptor tyrosine kinase, and they will increase axon or dendritic proliferation. Dendritic proliferation, they will increase it. Now what happens if that is increased? There is more synapse. So there is increase in synaptic connections. So in the brain there will be more connections. Imagine that if you are alone, obviously you are depressed. If you have more connections, if you have more friends, depression will go. Same thing, brain has to form more synapses. So more synaptic connections, and that we call it as neuroplasticity. We call it as neuroplasticity. So this will also take this proliferation and synapse, all these things, 2 to 3 weeks to start working. So remember, antidepressants will not work immediately, they take their time. So there are two theories proposed. One is desensitizing the receptor and releasing the neurotransmitter. Second one is neurotropic hypothesis by increasing mainly BDNF. I will simplify the things. Increase the BDNF, increase the synapses. If you increase the synapses, depression can be treated. That's it. So that is the mechanism proposed for tricyclic antidepressant and other antidepressants also, particularly the neurotropic hypothesis. Now, what about the TCA drugs? Now, TCAs, I told you, tricyclic antidepressants, they will inhibit non-reuptake, correct? They inhibit serotonin reuptake, correct? Yes, we are correct with that. But one specialty is these TCAs, they also block alpha receptors, they also block histamine receptor. Now tell me, if you block alpha receptor, what is the adverse effect patient will have? Obviously, patient will have hypotension. The BP falls. If the patient half histamine is blocked in the brain, yes, he will have sedation as a problem. Very good. Now, another receptor is muscarinic receptor. What happens if you block muscarinic? It is nothing but the cholinergic, anticholinergic adverse effect what we see. Patient will have blurring of vision. Blurring of vision. Can you tell me why blurring of vision? Come on, come on. Because when you block muscarinic receptor, there is a chance of passive mydriasis. Passive mydriasis similar to atropine. Now, if it causes passive mydriasis, the question asked in your exam is, can we use this TCS in a patient with closed angle glaucoma? Can we use it in a patient with closed angle glaucoma? Yes, pause the video and try to answer. Can we use TCS in a patient with closed angle glaucoma? No. If you use mydriatics, they will close the angle further. So TCS are contraindicated. So any mydriatic is contraindicated. Very important clinical application. The second important aspect when you block the muscarinic receptor is patient will have dryness of mouth. Then constipation. Then urine also gets retained. So urine retention. Urine retention. Can we utilize this urine retention in some condition? Yes, we can use it in enuresis, nocturnal enuresis, where the urine is coming out at the night time. So there we can use it. Now another important aspect is they can cause tachycardia. And the tachycardia can develop into arrhythmia, that is long QT. So patient may develop long QT syndrome if you are using these TCS at high dose. Long QT can happen. So this is what the TCS, and you know the adverse effect with them. Now another important problem with the TCS. Now TCS are not efficacious for depression. So they are only reserved in the end. They are not so much efficacious and they have narrow therapeutic index. They have narrow therapeutic index. So that's why we are not using them very common to treat depression nowadays. So coming on to the TCS, we understood how the TCS works, mechanism of action. Let us understand the drugs. What are the tricyclic antidepressant? What are the drugs here? The name of the drugs are imipramine. The name is imipramine. Now the imipramine after metabolism will give rise to desimipramine. Desimipramine. Now they can ask in the exam, is it an example of prodrug? No. Imipramine is also active. The metabolite is also active. Imipramine is used mainly to manage nocturnal enuresis. Nocturnal enuresis. Now what is the problem here? Nighttime there is passing of urine in the bed. Now it has the anticholinergic property, so it can retain the urine. That's the reason imipramine is used. Then we have a drug called amitriptyline. After metabolism, it will give rise to nortriptyline. So amitriptyline and nortriptyline. Amitriptyline is used in neuropathic pain. Can you tell me some other drugs used in neuropathic pain? Gabapentin, yes. Then pregabalin, GABA. Then one more, carbamazepine, correct. So it is used in diabetic neuropathic pain. And also it is used as a drug for migraine prophylaxis. The name is amitriptyline. Apart from that, we have a drug called cloimipramine. The name is cloimipramine. It has particularly shown to increase the activity of serotonin. And it is a drug which is used to treat a condition called OCD. OCD means obsessive compulsive disorder. There we use it. Then we have a drug called doxepin. Now doxepin has histamine blocking property. So that is highest with that. Because of that, it is used to treat pruritus, itching. We know that for itching we use antihistamines and we use it as topical drug. So doxepin is there. And one more older drug is called as dotiepin. So it is called dotiepin. First, remember in this, mainly what we are dealing is the imipramine, amitriptyline, cloimipramine, doxepin. These are very, very important. Nowadays, the use of TCAs are not that much because they have narrow therapeutic index, adverse effect are more, efficacy is less in depression. So only in the end we use them. If we have used the normal drugs, that is SSRI, SNRI, still the depression is there, then we are going to use them. Otherwise, you can see the uses, they are used in other conditions. Another important thing they will ask you in an exam is the TCA toxicity. TCA, overdose or poisoning. So there is a risk that when we prescribe TCS, many patients, any depression patient may have the risk of suicide. They can take the tablet and come. Now in TCA overdose, remember 3 C's that can be seen. Convulsions can be seen. And cardiotoxic. Now what is the reason for cardiotoxicity? The reason is these are having anticholinergic properties, so they can increase the heart rate, tachycardia, and they can also increase the long QT. They can produce the prolonged QT interval, and they can also cause arrhythmia. And patient may slip into coma. These are the 3 C's what you see with TC overdose. Similarly, we can also see the 3 C's with atropine poisoning. Along with that, you see high anion gap acidosis. So high anion gap acidosis is also seen with this poisoning. So how do you management? So the management is similar. Any poison, we maintain the airway breathing circulation. Then if the tablet is not absorbed, we do gastric lavage. So better to be done within 6 hours. And then we use the antidote. So what is the antidote for this TCA overdose? Any guesses? Yes, it is the intravenous sodium bicarbonate. Now, why are we using this? Most of you are thinking to make the urine alkaline. No. The reason why we are using it is, you should know the reason for this. Whenever there is TCA overdose, TCAs, they block sodium channels in the heart. They block sodium channel in the heart, and that is going to cause arrhythmia. So when we use this sodium bicarbonate, it will not allow the sodium channel blockade, and it will overcome the sodium channel blockade, and it will prevent arrhythmias, and it can prevent the death. So that's the reason. Please understand that drug will only prevent arrhythmia, it will not treat arrhythmia. Correct? So along with that, it will also treat acidosis. These are the 2 reasons why the drug of choice or antidote is IV sodium bicarbonate. Suppose the patient develops seizures. The drug which can be used is a benzodiazepine called lorazepam or diazepam can be used. Patient may develop arrhythmias. So if it is the supraventricular arrhythmias or the ventricular tachycardia, the drugs used are lignocaine. Lignocaine for ventricular arrhythmias. If it is atrial origin arrhythmia, we can use beta blockers. Now, please understand which group of antiarrhythmics are avoided. Which group of antiarrhythmics are avoided? Any idea? It is class 1A antiarrhythmics and class 3 antiarrhythmics. Why do we avoid these antiarrhythmics in poisoning and to treat arrhythmias? If arrhythmia occurs, either we give lignocaine or beta blockers in that case. Now, why we avoid this? Because they increase QT interval. Already in this poisoning, we have QT interval prolonged, and if I use this, it will worsen it further. So avoid class 1A and class 3 antiarrhythmic drugs. You can use lignocaine or beta blockers in this case. So that is the management of TCA overdose. So once we know the TCAs, it's important that we know another group of drug which also inhibit uptake, and they are called as SNRIs. They are called as SNRIs. This is the third group. Now, what do you mean by SNRI? The meaning is serotonin, noradrenaline, reuptake inhibitors. So SNRI stands for serotonin noradrenaline reuptake inhibitors. Now, what is the mechanism of action? They inhibit noradrenaline reuptake and they inhibit serotonin reuptake. And also they increase the BDNF. So these are the three things what you see with them, SNRIs. Now compared to TCAs, what you don't see is no alpha blockade, no muscarinic blockade, no histamine blockade. So that is the advantage. These adverse effects are not seen compared to TCS. Now SNRIs are used to manage the general anxiety disorder. They are used in neuropathic pains. They are used in neuropathic pain. They are used in OCD. So these are some of the important uses of SNRIs. And they are also effective in depression. They can also be used to treat depression. Okay. So these are the uses of SNRIs. Sir, what are the SNRI drugs we have? Let me tell you. What are the drugs here? What are the drugs here? The name is venlafaxine. The name is venlafaxine. If you add des, again you get one more drug. It is called desvenlafaxine. So we got two drugs here, venlafaxine and desvenlafaxine. Another drug is called, the name is called milnacipran. The name is called milnacipran. Apart from this, it is also used for one more condition, that is fibromyalgia. It is also used in a somatoform disorder, that is fibromyalgia. Another drug is duloxetine. Duloxetine is also used to treat the same condition, that is fibromyalgia. Apart from that, it is used in a condition called stress urinary incontinence. It is also used in stress urinary incontinence. Sir, what is that? Now, whenever the stress is put on that, the urine will come out. When somebody coughs, sneezes. Now, in this stress urinary incontinence, now why we are using this? Because it has muscarinic blockade property also. And you know that when you block muscarinic receptor, there is urine retention. That's the reason it is used. Another important use of this drug is, I told you these are used in neuropathic pain. This is used in diabetic neuropathy. So duloxetine is used in fibromyalgia. It is used in stress urinary incontinence and neuropathic pains, that is diabetic neuropathy. Milnacipran, it is used in fibromyalgia. So remember these drugs, remember it starts with ven, milna and dulox. These are SNRIs. But the problem with these drugs are, what happens if you are not allowing the noradrenaline to be taken up back in the synapse, particularly in the brain? So what do? They don't allow noradrenaline to go back. So that is inhibited. When the noradrenaline increases, it acts on the alpha receptor, it acts on beta receptor. So patient may have increase in BP and increase in heart rate as the adverse effect. So this is one of the main adverse effect what we see, increase in BP, increase in heart rate with the SNRI. So we came with one more concept and one more group of drug came to the market, and they are called as SSRIs. They are called as SSRI. What do you mean by SSRI? The meaning is selective serotonin reuptake inhibitors. So they are called as selective serotonin reuptake inhibitors, the SSRIs. Now, what is the drug name here and what is the mechanism of action? They inhibit only the serotonin reuptake and they also increase the BDNF. Will they work faster? Never. They will also take 2 to 3 weeks to start working and their action peaks at 4 to 8 weeks. Sir, what are the advantages compared to advantages over TCS? Why these are preferred nowadays to treat depression? They can ask you. Point number one, these have no alpha blockade, the muscarinic blockade or histamine blockade, no problem. Now, if you tell TCS, they have narrow margin of safety, so their safety is good. And efficacy is also good. So safety and efficacy is good compared to TCS, and also they don't cause no psychomotor or cognitive impairment is seen. The reason is simple. They have anti-collisive property which can cause cognitive and psychomotor impairment, that is not seen. So this is the advantages of SSRIs over TCS. Advantages over TCS. So once I know the advantages, I should be knowing the drugs. What are the drugs we use? The name of the drugs are fluoxetine. The name is fluoxetine. Now fluoxetine in the body is metabolized to one more active compound and that is called norfluoxetine. Norfluoxetine. And if fluoxetine works for 50 hours, norfluoxetine acts for another 150 hours. So the duration of action is long. If they ask in the exam, what are the longest acting SSRI? The first one is the longest acting. So longest acting SSRI. Moving on to second, if you know the longest acting, the next one I am going to write is the shortest acting. It is called fluvoxamine. Fluvoxamine is the shortest acting. Shortest acting. Then we have another drug and that is called paroxetine. So if you know fluoxetine, there is a drug by the name paroxetine. And avoid, P for pregnancy. Avoid in pregnancy. So if I am telling avoid in pregnancy, it would have caused some problem in the fetus. So it causes serious defect in fetus. It causes serious defect in the fetus. So remember P for pregnancy. You should avoid it. Don't give it. Avoid. The fourth one is sertraline. Sertraline. And number 5 we have citalopram. Citalopram. For that, if you add es, it becomes escitalopram. So this is called the most specific SSRI. It is the most specific SSRI, escitalopram, and the last one is duloxetine. The name is duloxetine. So these are the SSRIs. So let us try to remember these drugs. I know you have a difficulty in that. Fluoxetine. If you know oxetine, fluoxetine, paroxetine, duloxetine. Then fluoxamine. Then we have the citalopram. If you add escitalopram. Sir, if I don't know, it is called sertraline. These are the drugs what we have as SSRIs. Now, nowadays, SSRIs are the first choice in treating depression. So what are the uses of SSRIs? Let us understand. Uses. They are used in mild to moderate depression. They are the drug of choice. So they are the one which we start for the patient with depression. Second, they are also used in OCD, obsessive compulsive disorder. They are used in phobic, phobia and panic disorders. They are also used in GAD, general anxiety disorder, GAD, and they are used in PTSD, post traumatic stress disorder. So when you read this topic, try to correlate with psychiatry and read, it will be easier for you. So post traumatic stress disorder or binge eating disorders, binge eating and bulimia nervosa. So these are the conditions where we use it. Now one more condition where we use it is a condition called premature ejaculation. So we use SSRI in premature ejaculation, and the drug that is approved for that is duloxetine. So duloxetine is approved. I know you will confuse with the drug duloxetine. So that's the reason P. Remember P for premature ejaculation, and it is an SSRI. This is the confusion you will have. So let me repeat: depression, OCD, then phobia, panic disorder. Then we also use it in anxiety disorder, general anxiety disorder. Then we use it in the binge eating, then the bulimia nervosa and premature ejaculation. In premature, it is mainly duloxetine is FDA approved. Once I know the uses, it's important that I understand the adverse effect of serotonin. Now, why I need to understand the adverse effect of serotonin? Because SSRIs, when I give SSRI, what do they do? SSRIs, they increase the serotonin activity everywhere. So it will increase. So what happens if serotonin increases? It acts on the receptor 5HT2. So when it acts on the 5HT2 receptor, patient may develop anxiety. Patient may develop anxiety. So it's very important when you're treating a patient with depression, you should know this concept that initially he may develop anxiety. So suppose a patient comes with depression and you use these drugs and he will have anxiety. Because of anxiety, he may not take the drug or he may do something else. So that's why initially what we do is we add benzodiazepines along with that to avoid this anxiety. So anxiety is seen initially only, but later it will subside. So the same thing we apply when we manage general anxiety disorder. When you give SSRIs, initially there will be anxiety. So what we do is we give benzodiazepine and they will suppress the anxiety. After some days, this anti-anxiety effect comes to the picture and they will work. You may ask a question, sir, why can't we use benzodiazepine only to treat anxiety? The problem with benzodiazepines are they can cause sedation, they develop tolerance, and they can cause dependence to the drug. That's why we don't want to use them for a very long period. So SSRIs are used. But if the patient comes with acute anxiety, the drug which can act immediately is benzodiazepines only. SSRIs will not work immediately in managing anxiety. Remember, the adverse effect initially is anxiety. Second, they can produce insomnia. Now, why this point is relevant in your practice? Suppose a patient comes and he tells that I have depression and I cannot sleep at the night. Suppose if you use SSRIs, patient will not have sleep. If he doesn't sleep, again depressed. Another important point is, will you prescribe SSRIs in the morning or in the night time? If you give in the night time, he will not sleep. So better to give these drugs in the morning time. This is the application of that. Another important aspect is it is known to produce sexual dysfunction. Now, what is a sexual dysfunction we see? One is anorgasmia. So the orgasm is not obtained and delayed ejaculation. So ejaculation is delayed, but we take the advantage of this. And I told you the drug that is used to treat premature ejaculation is an SSRI, and that is called duloxetine. And serotonin can also cause bruxism. So bruxism means grinding of teeth. That is also seen. The excess of serotonin can also act on the receptor called 5HT3. And we know that these receptors are present in GAT and CTZ. And patient may develop nausea, vomiting, and diarrhea. So your favorite adverse effect, nausea and diarrhea, is shown by them. Not only that, these will also act on 5-4, and that is also responsible for causing diarrhea. So these are the adverse effect what we see with SSRI. Again, repeatedly asked question in your exam, all are seen except anxiety initially, insomnia, sexual dysfunction, bruxism, nausea, vomiting, diarrhea, and what are the other adverse effect what we see with this? Now, what are the other adverse effect is certain times what happens when we are using serotonin, when you start them, certain times when you are using SSRI, when you stop them suddenly, there is a problem called discontinuation syndrome. Discontinuation syndrome is seen. That means when you stop this, particularly this is seen when you abruptly start shorter acting ones in SNRI, the venlafaxine. In SSRI, the shorter one is fluoxetine, no, fluoxamine. Because fluoxetine is longer acting, even if you discontinue, it will work for another 200 hours. That is not seen. And one more is sertraline. So these are shorter acting. So once you discontinue that, the drug's effect is worn off and patient will develop this problem. What are the problem patient will develop? So patient will develop the problem that is flu-like symptoms. He will develop flu-like symptoms. And another important he develops is insomnia. And he will develop the nausea and vomiting. Patient may develop imbalance. He will develop imbalance and sensory disturbances. Sensory disturbance. And hyperarousal. It is called hyperarousal. Patient may develop anxiety and all. So these are the discontinuation syndrome. The mnemonic is finish. Right? So this can develop when you suddenly stop the shorter acting. The question is, will it be seen with longer acting like fluoxetine? No. So it is only seen with shorter acting. Another application when serotonin is excess is the development of serotonin syndrome. Development of serotonin syndrome. Yes. So if the serotonin levels are high, more the 5-ST, the risk of serotonin syndrome occurs. What is seen in serotonin syndrome? It is hyperthermia, myoclonus, then rigidity of the muscles, and patient may develop seizures. Now these are the problem with serotonin syndrome, and what is the drug of choice? Block the serotonin, and that is called cyproheptadine. Cyproheptadine is a 5-HT2 antagonist. So when serotonin is excess, they are going to develop serotonin syndrome, hyperthermia, myoclonus, rigidity of muscles, seizures. And drug of choice is cyproheptadine because it blocks the 5-HT2 receptor. It is cyproheptadine. Now when the risk increases? Now when you combine MAO inhibitor plus SSRI, or we combine pethidine, which increases serotonin, with SSRIs, or when you combine linezolid. Linezolid has a MAO inhibitor property with SSRIs, or when we use dextromethorphan, a cough suppressant with SSRIs, then also the risk has increased. So these are the places where the risk of serotonin syndrome has increased because they also increase the level of serotonin. Both increase the level of serotonin. Right? So wherever two drugs increasing serotonin are given, there is a risk of serotonin syndrome. Please keep that in your mind. Okay. Right. Okay, so once we learned about SSRIs, so next group of drugs, in antidepressant, we are going to discuss something called atypical antidepressants. Atypical antidepressants. depressants. Now, the reason why they are called atypical. Now, what I told you in the beginning, antidepressant drugs either they inhibit the serotonin uptake or noradrenaline reuptake, or they inhibit MAO. But these have some of the atypical mechanisms, and that's the reason they are called atypical antidepressants. So, in that, the number one, we have an alpha blocker, so which blocks both alpha 1 and alpha 2 blocker. Not only that, it is shown to block 5-HT2 also. So these drugs which block both alpha 1 and alpha 2 and 5-HT2, we have the drug, and the drug name is called trazodone. So the drug name is trazodone, and important adverse effect that is asked with that is it can cause priapism. Priapism, the reason for priapism is it is a alpha blocker, so it can cause vasodilation and cause the erection, and the erection may be prolonged, and that will lead to painful erection, that is called priapism. And also it has shown to produce cardiac arrhythmias. Another drug we have is nefazodone. So nefazodone, one of the important adverse effect is hepatotoxicity. These are hepatotoxic drugs. So that is trazodone and nefazodone for you. The next drug what I am going to discuss is a blocker of presynaptic alpha 2. The drug blocks presynaptic alpha 2. Now when you block presynaptic alpha 2, what happens is there is increase in noradrenaline release. You know that when we stimulate presynaptic alpha 2, there is decrease in noradrenaline release, but when I block it, there is increase in release. And the drug name is called mianserin. The name is called mianserin. Now, one more important drug what we are going to discuss is the name called NASA. Now, what is the full form of NASA? The full form is NA stands for noradrenergic. So let me write the full form for you. NA stands for noradrenergic and specific serotonergic antidepressant. So that is the full form of NASA. Now the name of the drug which is present here is mirtazapine. So mirtazapine is a NASA. Now how does that work? Now the mechanism is beautifully explained for this. This is the noradrenergic neuron, and let me write, this is the serotonergic neuron. Yes. Now I told you the role of alpha 2. The role of alpha 2 is to decrease noradrenaline release, and if it is present in the noradrenergic neuron, that is called autoreceptor. If alpha 2 is present in the adrenergic neuron or noradrenergic neuron, it is autoreceptor. If it is present in the serotonergic neuron, then it is called as heteroreceptor. So alpha 2 in serotonergic neurons, it is heteroreceptor. So there also it decreases serotonin release. Now you think and tell me, if I want to increase the release of noradrenaline and serotonin, should I stimulate alpha 2 or block it? Obviously, I have to block this. So when I block this receptor using mirtazapine, there is increase in noradrenaline release, increase in serotonin release. So that is the mechanism of action proposed for this. So it's a alpha 2 blocker, and it can block the autoreceptor, that is alpha 2 in the adrenergic neuron. It blocks the heteroreceptor in the serotonergic neuron, that is the mechanism. It increases both noradrenaline and serotonin. But the other specialty of mirtazapine, let me write here. You understood the mechanism. Mirtazapine. This drug mirtazapine, and I told you it's a alpha 2 blocker presynaptically. Along with that, the drug is a 5-HT2 blocker. Now remember, more the serotonin, more the sexual dysfunction. I'll repeat again, more is the serotonin, more is the sexual dysfunction. That's why SSRIs, TCAs, SNRIs, they can cause sexual dysfunction. Since it blocks the 5-HT2 action, this drug is shown to produce less or no sexual dysfunction. No or less sexual dysfunction. So this was the question asked in your recent exams. Please mark it. Second, it also blocks 5-HT3 receptor. And one more importance of mirtazapine is it's also an histamine blocker, particularly H1. Now you know that when you block H1, the problem is sedation. So mirtazapine can not only treat depression, it can also cause sedation. Now, which patient it will be useful? Mirtazapine will be useful in a patient with depression plus insomnia. So if a patient has depression with insomnia, you can use this because it causes sedation. Can you tell me that depression with insomnia can be SSRIs? No, because SSRIs themselves cause insomnia as adverse effect. So mirtazapine is the NASA. The meaning is noradrenergic and specific serotonergic antidepressant. Moving on to the next drug, and the name of the drug is called bupropion. The name is bupropion and it is called as NDRI. Sir, what is NDRI? NDR stands for noradrenaline dopamine reuptake inhibitor. It is noradrenaline dopamine reuptake inhibitor. So until now we were telling that you have to inhibit the reuptake of noradrenaline serotonin, but it will also inhibit dopamine. So that's why they are atypical antidepressants. Now where do I use this? Bupropion is used in smoking cessation therapy. Smoking cessation therapy. Now what happens in smokers? They smoke, the nicotine enters, nicotine releases dopamine that will cause relaxation. So they want to smoke again and again. Now how come this will help? Because bupropion also increases dopamine, so the craving decreases with that. So that's why it can replace the nicotine. So bupropion is used. Second important is bupropion is used in the management of obesity. Bupropion is used in the management of obesity and also in the management of depression. So it can be used to treat depression also. In the exam, they can ask a question. Patient is having depression and he wants to quit smoking. Which antidepressant is preferred is bupropion. But one important problem with bupropion is it can cause seizures. And also it can increase anxiety. So that is the problem with bupropion. Remember, bupropion should not be confused with a drug called buspirone. Don't confuse this because buspirone is a 5-HT1A partial agonist. It's a 5-HT1A partial agonist and that is used to treat chronic anxiety or generalized anxiety disorder. So many times you will confuse bupropion and buspirone. This drug is not an antidepressant, but I am telling you to compare and avoid the confusion in the future. So buspirone, remember bus, snake. So buspirone, when you see the snake, anxiety. So for that, what we use is buspirone. The other atypical antidepressants, what I want to tell you is a drug by the name amoxapine. The name is amoxapine. Amoxapine is chemically related to one more drug, loxapine. So loxapine is a D2 blocker and it is used in the treatment of psychosis. So it is chemically related to loxapine. Amoxapine as such is an antidepressant. It's an atypical antidepressant. So when I give this amoxapine, I can treat two important conditions, depression as well as psychosis. So patient can be treated with both the conditions. So the use of this drug is to manage depression plus psychosis. So what we call it as psychotic depression, we can use it. The next drug, what we have is a drug by the name agomelatine. Agomelatine sounds like melatonin. Yes, you are right. You heard it right. It acts on melatonin 1 and 2 as agonist. It's a melatonin receptor agonist. You know, melatonin is required to induce sleep, and also it is a antidepressant that is atypical. So which patient do you prefer giving this? Yes, obviously, a patient who suffers with depression plus insomnia, in them we can prefer giving agomelatine. Yes. Okay, so we are done with agomelatine, which can be used for depression plus insomnia. One more group of drug which act peculiarly. You can see the peculiar action. They increase the serotonin reuptake. So they act by increasing serotonin reuptake, and that's why these mechanisms are called as atypical. So the name is amineptin, and one more is called tianeptin. These are the atypical antidepressants. So number one, trazodone, nefazodone. Then we have mianserin, mirtazapine, bupropion, agomelatine. Then we have amineptin and tianeptin. So once we are done with this, are there any newer drugs for depression? Newer antidepressants. So newer is also called as novel antidepressants. Is there any novel antidepressants? Yes, there are few. In that, the first one is that spray called S-ketamine nasal spray. S-ketamine nasal spray. Now this is used for resistant depression, not for the routine treatment of depression. If the depression is not treated with the normal drugs, still the depression is there, then it is preferred resistant depression. Next, a drug called brexanolone. Now, brexanolone is mainly used to treat a depression seen in postpartum period, that is called postpartum depression. So there it is approved. The specialty is it is given as 60-hour continuous infusion, and that is called brexanolone. Now, recently we have come up with certain drugs. The name is called vortioxetine. And one more drug is called vilazodone. The name is called vilazodone. Recently they had asked this question in the exam. Which of the following is novel antidepressant? Now vilazodone is also called by the name sparring. Now what do you mean by sparring? So S stands for serotonin, P for partial, and A for agonist. So it's a 5-1A partial agonist. So it's a 5-1A partial agonist. And also RI stands for reuptake, I for inhibitor. So it has dual action. It's a 5-1A partial agonist, and also it has the SSRI property. So that is a novel antidepressant vilazodone. Vortioxetine is also having the same property. It also inhibits 5-HT reuptake like SSRI. It's also a 5-HT1A partial agonist. PA means partial agonist. And also it's a 5-HT3 blocker. These are the two novel antidepressant, vortioxetine, vilazodone. Where to use them? They are used for major depressive disorder. They are used in major depressive disorder. The name is vilazodone and vortioxetine. So these are the new drugs in the market that can come as a potential question in the future exams. Right? So we are done with the newer drugs. Esketamine nasal spray used in resistant depression, brexanolone for postpartum depression, voltoxin, vilazodone. Vilazodone is aspirin. So they both are approved for major depressive disorder. Another important thing they ask in your exams is now what drugs used in depression can cause sexual dysfunction? What drugs used in what drugs used in depression treatment can cause sexual dysfunction? Remember, more the serotonin, more the sexual dysfunction. So SSRIs, SNRIs, TCS. So they can cause sexual dysfunction because all these three enhances the serotonin activity. Now, what drugs they cause less or no sexual dysfunction? What are the drugs? Now, the drugs are bupropion, an atypical antidepressant, bupropion. Second important one is mirtazapine, and two novel one that is called vilazodone, and one more is called vortioxetine. So this has less or no sexual dysfunction. So this is about the antidepressant. Let me summarize the things. Now, when we think of antidepressant drugs, their aim is to increase noradrenaline, serotonin, and increase brain-derived neurotrophic factor. How can you do that? By inhibiting MAO. But MAO inhibitors are outdated. Only thing you have to remember is cheese reaction. And how do you manage it? By using phentolamine. The second group of drugs are TCS. They not only inhibit the uptake, they inhibit alpha receptor, histamine, muscarinic receptor, leading to adverse effect. They are not used in depression because of less efficacy and more adverse effect. Imipramine is used in nocturnal neurosis. Amitriptyline is used in diabetic neuropathy and migraine prophylaxis. Then we came with SNRI, venlafaxine, milnacipran, and duloxetine. They are used in same conditions like anxiety, neuropathic pain, depression, all these things. But duloxetine is used in a condition called stress urinary incontinence. Then we have SSRIs. SSRIs, the names are paroxetine, fluoxamine, then citalopram, escitalopram, duloxetine. These are the drugs what we use for depression, OCD, PTSD. Then we use it for binge eating disorder, and also they are used in premature ejaculation. They are also used in general anxiety disorder. Now, most important thing is adverse effect, which they will ask in the exam. They can produce nausea, vomiting, diarrhea, anxiety initially. To avoid that anxiety, what we add is benzodiazepine. Then they can cause insomnia, sexual dysfunction, delayed ejaculation, and discontinuous syndrome. Serotonin syndrome is a risk factor when you use two drugs which increase serotonin levels. The treatment is iprapiridine. Then we came with atypical antidepressant. The most important is mirtazapine, NASA. We prefer in patient with depression with insomnia. Then we have bupropion used for smoking cessation and depression and obesity. It can cause seizures. And one more important one is the agomelatine, which can cause melatonin stimulation and antidepressant property. The newer or novel antidepressants are esketamine nasal spray, then brexanolone used in postpartum depression, and vortioxetine and vilazodone. These are the novel antidepressant. So that is about antidepressant topics. Now, whenever a patient presents with depression, what are the principles of treating depression? What are the drug therapies what we use? So, principles of drug treatment of depression. So we have many drugs what we discuss, but what we start. Now remember, when a patient is diagnosed with depression, the psychiatrist will start SSRIs are the first choice. So they are the first choice for managing depression. Then please tell the patient it will not work immediately. It will take 2 to 3 weeks to start working. And the full effect is seen around 4 to 8 weeks. 4 to 8 weeks are required to produce the full effect. Now, should the patient stop it? Let us decide that. Now, if SSRIs are not suitable For example, depression with smoking, depression with insomnia. Alternatively, what you can do is, alternatively you can start SNRI or atypical ones. Yes. Now, if patient is on antidepressant is okay now, depression controls. Should I stop the therapy? No, you should not stop the therapy. You have to continue. That is called maintenance therapy. Maintenance. Now, why should I give maintenance therapy? The reason why we give maintenance therapy is to decrease the relapse of depression again. Next. Now, this is what we do. But now, sometimes you can ask a question, sir, when to add TCS? TCS, we usually give these drugs, and if patient is not responding, non-responding cases to these drugs, then only we add. Non-responding cases, we add TCS. Now, suppose a patient has suicidal tendency. So what we do is, we have to give electroconvulsive therapy, ECT, electroconvulsive therapy. So this is the principles usually followed for managing depression. Now, patient coming with depression, SSRIs are the first choice. Please tell the patient 2 to 3 weeks to start working. The maximum effect is seen in 4 to 8 weeks, that is 2 months. Now, if SSRIs cannot be started, you can start the SNRI atypical ones to the patient. Now, once you see the full effect and the depression is controlled, should I stop the drug? No need, because you have to maintain therapy. Because if you don't give the maintenance therapy, there is a chance of relapse. So maintenance therapies will decrease the relapse of depression. And many a times, if the patient doesn't respond with these drugs, then only we come to TCS. If they have suicidal tendency, better to give electroconvulsive therapy. Right. Thank you all.